Today, I am diving into malaria, a major public health challenge and a concern for UK travelers. With my experience treating malaria patients, I'll cover its types, anatomy, causes, symptoms, diagnosis, treatments including my specific approach, home remedies, the most affected gender, and how age plays a role. Let's get started. What is malaria? Malaria is a life-threatening disease caused by Plasmodium parasites, transmitted through bites of infected female Anopheles mosquitoes. In South Asian country and tropical countries Africa, it's a significant issue, with approximately 1 million cases and 50,000 deaths annually, especially in flood-affected areas in the UK. Approximately 1,500 to 2,000 cases are imported yearly by travelers, with 10 to 20 deaths. Malaria affects all ages, and early diagnosis is critical to prevent severe outcomes. Types of malaria is caused by 5 Plasmodium species. Plasmodium falciparum, most severe, causing approximately 75% of UK cases, leads to cerebral malaria and organ failure if untreated. Plasmodium vivax, most common in Pakistan, approximately 77% of cases, causing relapsing fever due to liver hypnozoites. Less severe but persistent. Plasmodium ovale, rare, like vivax with relapses. Plasmodium malariae, causes chronic, milder infections. Plasmodium knowlesi, emerging in Southeast Asia, rare in Pakistan, UK, can be severe. Mixed infections, e.g., falciparum plus vivax, increase complexity. Anatomy and physiology. Malaria affects the blood and organs. Anatomy. Parasites invade red blood cells, RBCs, liver, and spleen. Anopheles mosquitoes inject sporozoites into the bloodstream, which travel to the liver to form merozoites, then infect RBCs. The spleen filters infected RBCs, and the brain may be affected in cerebral malaria. Physiology. Infected RBCs rupture every 48 to 72 hours, depending on species, releasing toxins, causing fever and chills. P. falciparum causes microvascular blockage, leading to tissue hypoxia, organ dysfunction. Kidneys, brain. P. vivax hypnozoites in the liver cause relapses. Severe malaria triggers systemic inflammation, anemia, and hypoglycemia. Causes. Etiology. Malaria is caused by Plasmodium parasites, with risk factors varying by region and age. Primary cause. Bite of infected female Anopheles mosquitoes, active at dusk and dawn. Risk factors. Endemic in 98% of the population, with high transmission in rural areas, standing water, and post-flood conditions. Floods increased cases to 3.4 million. Poor sanitation, low bed net use, and limited healthcare access. UK. Imported by travelers to endemic areas. Sub-Saharan Africa, Pakistan. Non-immune UK residents and Pakistani diaspora visiting relatives are at risk. Environmental. Warm, humid climates and stagnant water breed mosquitoes. Socioeconomic. Poverty, migration. Afghan refugees in Pakistan and lack of insecticide-treated nets, ITNs. Age-specific risks. Children, less than 5, high mortality due to low immunity, especially in Pakistan. Young adults, 18 to 40, occupational exposure. Outdoor work. Elderly, greater than 60, comorbidities increase severity in both regions. Other factors. Drug-resistant strains, e.g., chloroquine-resistant P. falciparum in Pakistan, and inadequate prophylaxis in travelers. Signs and symptoms. Malaria symptoms appear 7 to 30 days post-bite and vary by severity. Common symptoms: fever, chills, and sweating. Cyclical every 48 to 72 hours. Headache, muscle aches, and fatigue. Nausea, vomiting, and diarrhea. Severe malaria. P. falciparum. Cerebral malaria, confusion, seizures, coma. Severe anemia, jaundice, or dark urine. Hemoglobinuria. Acute kidney injury, pulmonary edema, or shock. Age variations. Children, fever, irritability, poor feeding, and seizures. Adults. Flu-like symptoms, often misdiagnosed in the UK. Elderly. Confusion and organ failure more common. Symptoms mimic flu or dengue, delaying diagnosis. How to diagnose malaria. Early diagnosis saves lives. Using clinical and laboratory methods. Clinical assessment. History of travel to endemic areas. Pakistan, Sub-Saharan Africa, or residents in high-risk zones. Symptoms like cyclical fever, chills, and flu-like illness raise suspicion. Laboratory tests. Microscopy. Gold standard. Thick and thin blood films identify Plasmodium species and parasite density. Repeated if negative. 3 samples. Rapid diagnostic tests, RDTs, detect plasmodial antigens, used in remote Pakistani areas or UK emergencies. Less reliable for non-falciparum species. PCR confirms species in complex cases, available in UK reference labs. Other tests. Complete blood count, shows anemia, low platelets. Liver, kidney function tests, assess organ damage in severe cases. Blood glucose, monitors hypoglycemia in severe malaria. Challenges in Pakistan. Empirical treatment due to limited microscopy leads to misdiagnosis. Urgent action. In the UK, test all febrile travelers. In Pakistan, prioritize RDTs in rural areas. Most affected gender. Men are more affected due to behavioral factors. Men. Higher incidence in Pakistan due to outdoor work, e.g., farming, construction, during mosquito active hours. In the UK, male travelers to endemic areas report more cases, approximately 60%. Women. Lower exposure but higher risk of severe outcomes in pregnancy, e.g., miscarriage, anemia. Pakistani women in rural areas face barriers to healthcare. Gender-specific education is vital, especially for Pakistani men and pregnant women in both regions. Malaria and age. Malaria impacts all ages, with distinct patterns. Children, less than 5, highest mortality in Pakistan. Approximately 50% of deaths, due to low immunity and poor nutrition. In the UK, rare but severe in traveling children. Young adults, 18 to 40. Common in Pakistan due to occupational exposure. Elderly, greater than 60, higher risk of severe malaria due to comorbidities in both regions. Global data. WHO reports 241 million cases annually, with Pakistan's burden rising post-floods. Cases are preventable with prophylaxis. Early intervention and prevention, e.g., ITNs, are critical across ages. Treatment. Malaria treatment depends on species, severity, and region. I'll share my clinical experience. Medical treatments. Uncomplicated malaria. P. falciparum artemisinin-based combination therapy. ACT, e.g., artemether lumefantrine, Riomet, for 3 days. Chloroquine is ineffective due to resistance. P. Vivax, Pakistan. Chloroquine, 25 mg per kilogram over 3 days, plus Primaquine, 0.25 mg per kilogram for 14 days, to clear liver hypnozoites. Screen for G6PD deficiency before Primaquine. Severe malaria. P. falciparum, IV artesunate, 2.4 mg per kilogram at 0, 12, 24 hours, then daily, until oral therapy is tolerated, followed by ACT. IV quinine, 20 mg per kilogram loading dose, then 10 mg per kilogram every 8 hours. If artesunate is unavailable, with doxycycline or clindamycin. Supportive care. Manage fever, hypoglycemia, and organ dysfunction. My treatment experience treating malaria patients, especially severe cases in Pakistan. I've managed many unconscious patients requiring urgent care. My protocol includes IV fluids to maintain hydration and blood pressure, using normal saline or Ringer's lactate. For diabetic patients, I avoid glucose-containing fluids 5% dextrose to prevent hyperglycemia, which worsens outcomes. Infusion omezole, omeprazole, 40 mg IV once daily to prevent stress ulcers, common in critically ill patients, reducing gastrointestinal bleeding risk. Injection oxidil, ceftriaxone, 1 gram IV daily to prevent or treat secondary bacterial infections. This approach stabilizes patients, particularly in resource-limited Pakistani settings, and addresses complications like diabetes. Rehabilitation. Post-treatment, monitor for relapses, P-Vivax, and manage anemia or organ damage. Prevention is key to reducing malaria burden. Chemoprophylaxis. Atovaquone proguanil, Malarone, doxycycline, or mefloquine for high-risk areas. Start 1 to 2 days, Malarone, or weeks, mefloquine, before travel. Continue 7 to 28 days post-return. Bite prevention. Use 50% DEET repellent, long-sleeved clothing, and insecticide-treated nets, ITNs. Advice: vector control. ITNs, indoor residual spraying, IRS, and clearing stagnant water. Chemoprophylaxis. Limited use due to cost. Atovaquone proguanil or doxycycline for flood-affected areas. Community efforts. Government programs distribute ITNs, but uptake is low in rural areas. Challenges: drug-resistant P. falciparum and poor healthcare access hinder control. Non-compliance with prophylaxis causes imported cases. Home remedies. These remedies support prevention and recovery, complementing medical care. Neem leaves boil and drink as tea to boost immunity. Ginger tea reduces fever and nausea. Add 1 teaspoon to hot water daily. Tulsi, holy basil, anti-inflammatory. Chew 5 to 6 leaves or make tea. Lemon water hydrates and provides vitamin C. Drink 2 to 3 glasses daily. Mosquito repellent plants. Grow citronella or lemongrass around homes. Hydration. Drink 2 to 3 liters of water daily to support recovery. Caution. Remedies don't replace antimalarials. If you found this video helpful, like, subscribe, and share for more insights on MedWise by Dr. Naeem. Comment below. What's your malaria prevention tip? Stay healthy,